హాయ్ ఫోక్స్, వెల్కమ్ టు మై ఛానల్ ది యావరేజ్ డర్మాడాక్. ఇక మొదలెడదామా? Dapsone, also known as 4,4-diamino diphenyl sulfone (DDS). It is a sulfone antibiotic. It was first used as a dye, then in sulfonamide prontosil they discovered antibacterial properties and they searched it is also sulfone, whether it has antibacterial properties or not. Then they found out it has bacteriostatic and weakly bactericidal properties. From then it is started to be used as a antibacterial. Now it is a principal drug in multi-drug therapy against leprosy. Coming to pharmacology, it is lipid soluble and absorbed well from gut, not affected by food intake. It reaches peak in just 6 to 8 hours with a bioavailability of 70 to 80%. Plasma protein bound percentage 70 to 90% with a T-half of around 24 to 36 hours. It crosses blood-brain barrier, placenta, and is found in human milk. So, if a lactating mother is on Dapsone, there are chances of baby to get adverse effect of Dapsone, nothing but hemolytic anemia. Formulations available are 25 mg, 100 mg tablets, 5%, 7.5% gel. Primarily, it is metabolized in liver by two ways: acetylation and hydroxylation. Hydroxylation is the major pathway. Dapsone being acting upon the enzyme N-acetyl transferase gets converted into monoacetyl dapsone. In hydroxylation, it gets acted upon by enzyme N-hydroxylase in liver and gets converted to dapsone hydroxylamine, which is active metabolite having strong oxidant property. Then Dapsone and its metabolites gets converted to glucuronides through glucuronidation. These dapsone glucuronide, monoacetyl dapsone glucuronide, dapsone hydroxylamine glucuronide, all are water soluble and gets easily excreted through urine and bile. Dapsone has significant enterohepatic circulation and it also gets excreted in bile. Coming to mechanism of action, bacteriostatic mechanism of action. It has very good action against leprobacilli because of less PABA, high sensitivity of enzymes and accumulation of dapsone inside bacilli. Inside the bacilli, after accumulating well, it acts on the enzyme dihydropteroate synthetase. Both dapsone and sulfonamides have same target, dihydropteroate synthetase, within the bacilli. And it also inhibits dihydrofolate reductase enzyme, ultimately leading to inhibition of DNA synthesis. It also has anti-eosinophilic monocyte and neutrophil property because it inhibits the enzyme myeloperoxidase, which is present in all these three cells. It is most useful in diseases where neutrophilic infiltrates gets accumulated in the skin because it has anti-neutrophilic property by inhibiting respiratory burst and chemotaxis. This myeloperoxidase enzyme is main component in respiratory burst. It gets inhibited, leading to control of neutrophil induced tissue damage. FDA approved uses are only three. One is leprosy, dermatitis herpetiformis, where it is also used for diagnostic purpose, also acne. Dermatological uses are divided into two types: consistent efficacy and variable efficacy. Coming to consistent efficacy, leprosy, dermatitis herpetiformis. Remember this as SLE, bullous eruption of SLE. Remember LE, L for linear IgA disease, E for erythema elevatum diutinum. Coming to variable efficacy, vesiculobullous diseases like pemphigus vulgaris, foliaceous, bullous pemphigoid, cicatricial pemphigoid, IgA pemphigoid. Vasculitis, leukocytoclastic vasculitis, urticarial vasculitis. Neutrophilic dermatosis like Sweets, Behçet's, Pyoderma gangrenosum. Other dermatosis like granuloma facial, annular, pustular psoriasis, panniculitis. Relapsing polychondritis rosacea, granulomatous rosacea, recluse spider bite. brown recluse spider bite, nodulocystic acne, amyopathic dermatomyositis. These are all variable efficacy. Coming to adverse effects, this is also divided into two types: dose related, idiosyncratics, which is dose independent. Coming to dose related, remember RBC, hemolytic anemia. Within the RBC, hemoglobin, methemoglobinemia. Hemolytic anemia is because of its active metabolite dapsone hydroxylamine. This has powerful oxidant property. Old RBCs are having less number of G6PD, so they are more prone to lysis. Because of this oxidative stress, there will be membrane lysis and formation of Heinz bodies and change in structure and shape of RBCs. These abnormal RBCs with changed shape and having Heinz bodies are recognized by spleen, and they get trapped inside the spleen. Spleen doesn't allow them into circulation. So normal RBCs reduces, automatically hemoglobin reduces, leading to anemia, hemolytic anemia, because of dapsone hydroxylamine. Methemoglobinemia, normal hemoglobin will have ferrous state iron. Methemoglobinemia, this ferrous state will get converted to ferric state, which is incapable of carrying oxygen. Normal hemoglobin only have capability of carrying oxygen. So patient will present with shortness of breath, cyanosis, headache, lethargy and chest pain. These two are just because of oxidative stress. So we have to give antioxidants and provide oxygen. Antioxidants like vitamin E, C and tablet cimetidine 400 mg TID. Now treating methemoglobinemia is through IV methylene blue 1 to 2 mg per kg, slow IV infusion over a period of 5 minutes, or orally methylene blue 100 to 300 mg. Methylene blue we have to avoid in G6PD deficients. And finally, blood transfusions and plasma exchange. Dapsone and human blood were collected and kept in lab, and they observed no hemolysis by direct dapsone action. In our body, liver will convert dapsone into dapsone N-hydroxylamine, which is a strong oxidant, and it leads to hemolytic anemia, mainly because of not dapsone, its metabolite dapsone hydroxylamine. Next, coming to idiosyncratic side effects, agranulocytosis. GI and liver side effects like nausea, anorexia and jaundice. Agranulocytosis clinical features will be fever, oral ulcers and pharyngitis. Dapsone hypersensitivity syndrome, peripheral neuropathy, mainly distal motor peripheral neuropathy. After stopping the drug, patient will get completely recovered from distal peripheral motor neuropathy within a weeks to 2 years. Psychosis. Coming to skin related idiosyncratic side effects, photosensitivity, erythema multiforme 10, erythema nodosum, morbilliform or macular eruptions. Coming to contraindications, absolute contraindication is prior hypersensitivity like agranulocytosis and hypersensitivity syndrome. Relative contraindications, pre-existing peripheral neuropathy, G6PD deficiency, allergy to sulfonamide antibiotics, significant organ dysfunction like heart, lung, liver and kidney. Coming to drug interactions, probenecid decreases renal excretion and increases dapsone levels. Other drugs having similar action acting on folate pathway, sulfonamides, which acts on same enzyme like dapsone, methotrexate and trimethoprim on dihydrofolate reductase, pyrimethamine, will lead to increased risk of hematological side effects like agranulocytosis, pancytopenia. All enzyme inducers reduces dapsone serum levels like antiplatelets, phenytoin, phenobarbital, carbamazepine, antifungals, griseofulvin, antiviral, efavirenz, nevirapine, rifamycins like rifampin, rifapentin, rifabutin. All these are enzyme inducers which reduces dapsone levels. Monitoring: before starting therapy, you have to check G6PD, retic count, CBC, LFT and RFT. During therapy, CBC with differential count to observe whether agranulocytosis and retic count to observe whether hemolysis is going on or not. Every month, every week in a first month, then twice weekly during second month, and then periodically. 3 to 6 months once. G6PD levels may be normal, but reticulocyte count may get increased because of ongoing hemolysis. Why? New RBCs will be produced as a compensatory mechanism to hemolysis. These new RBCs will have plenty of G6PDs, which make G6PD levels normal, but there may be going on ongoing hemolysis. So we have to see reticulocyte count also, not only G6PD levels, to diagnose hemolytic anemia early. Like, share and subscribe my channel, The Average Dermadoc. Thank you. Hasta la vista. До свидания.